All right, guys, we may as well get started. Thank you very much, everyone, for coming out on Friday night. I know it's raining. I know it's pretty miserable, and personally, I wouldn't be here if I wasn't giving the lecture. So well done for actually coming. Tonight, we'll try and go through most of the knowledge you'll need for obstetrics. It is fairly lengthy, but the benefit of obstetrics is that it follows a timeline, and we can go through that. Just an introduction, I'm very keen, those of you who come to my Vespa will know that I'm particularly keen about obstetrics, and so there's sufficient knowledge in this presentation that you'll all do very well if you know it. The slides may appear quiet or busy, so the ones that are up at the moment I've taken a bit of the information out just to make it a bit more lecture friendly. The ones that go up, of course, will have all the information on them, so you don't need to madly write down stuff that doesn't appear on the slides. It is a longer lecture, but we'll get through it. My advice is to use Prompt. For those of you who don't know, Monash Health has a database of all their protocols called Prompt, and you can message me if you don't have the login details for that. Use that like your Z-score depends on it, because it does have all the protocols for obstetrics, and Monash University likes to test details from those. Practice your OSCEs now. You're under at 200 days, which still seems like a lot of time, but it will sneak up on you. Practice your OSCEs, practice getting those under your belt so that you're confident when you walk in and you don't have to think about it. And don't pursue a career in O&G. It's competitive enough, and I don't need you guys competing with me, considering I'm doing a BMed Sci and will graduate with you, most of you guys. I drew this up for my Vespa. This is just the O&G matrix as far as I'm concerned. We'll cover all the obstetric stuff tonight. The gynecology stuff you'll hopefully have in other presentations, but it's just there for your reference later on. So obstetrics is basically a timeline, and it's best to study it as a timeline. So you begin with fertility at the start. The physiological changes associated with pregnancy then follow. Your antenatal care is the ones pregnant with the problems in early pregnancy. Your prenatal screening and diagnosis, your imaging during pregnancy, your infections during pregnancy, your medical disorders, your labour and delivery then, operative intervention, of course, the emergencies, which are the big ones in which they like to test in OSCEs, and then after you've delivered. So just a couple of quick slides on fertility. Basically, within 12 months, most women under 35 years should fall pregnant if they're having intercourse at the appropriate times, if they're having regular intercourse, and of course, there are a variety of factors that may contribute to why they're not falling pregnant. Eggs have a short viability, sperm have a longer viability, so the recommended advice for couples who are attempting to fall pregnant is regular intercourse 2 or 3 times a week. And ideally, sort of almost daily in the 5 days leading up to ovulation, which if the woman has a regular cycle, you can measure, because the sperm can last within the fallopian tubes for a couple of days. And that way, whenever the egg ovulates, there hopefully will be sperm to meet it. The graph on the right basically just shows the percentage of aneuploid embryos that a woman produces as her age increases. So it's just to say that age is one of the biggest factor that contributes to fertility. Of course, smoking, alcohol, body weight, drugs, all those common other things you should mention. I don't think it's likely as an OSCE station, but keep it up your sleeve. And this is what you would cover for history and examination in both the female and the male. And remember, in this case, it's one of the few obstetrics scenarios where you do have to consider the male and interview the male in depth. You do need to know the semen analysis. So you do need to know the terms and their definitions. You don't need to know the normal parameters. They will be provided in exams, but there's a common MCQ question. So you need to know that oligospermia means a low sperm count, azoospermia means basically none. Sperm morphology, teratto, means abnormal, and again, ascenozoospermia is abnormal sperm motility. Management is basically to resolve the contributing factors and refer to IVF. So that's basically all you need to know. The critical point is the semen analysis. You need to be able to, on an MCQ, determine whether it's a male issue, and if so, diagnose which one it is, or whether it's something like endometriosis or something and it's a female issue. This is just one slide on the physiological changes that are associated in pregnancy. And there are things to think about in terms of when you're taking history from a woman and if you're looking at biochemical markers. There's a lot more information, of course, in the detailed slides. But things to note are that women are at risk of postural hypotension, especially if they're supine. So when you're lying them down, you lie them on a left lateral tilt. So there's a wedge-shaped pillow that you put under their back. That's to basically get the uterus and the fetus off the major blood vessels, and so that you don't exacerbate or cause hypotension. You get this hemodilution, so there's a greater expansion in the plasma volume than in the red cell mass. So you've got to look out for that when you're interpreting results. Of course, their folate and their iron demands go up. It is a hypercoagulable state, and we'll talk about that later, but DVTs, PEs, they're at increased risk of that. Insulin resistance and glucose intolerance is common in pregnancy, so they develop gestational diabetes, which is, of course, a risk factor for future diabetes, just the normal types. And of course, there's the Sheehan syndrome, which is what Monash loves to test, which is where the pituitary expands, the lactotrophs in the pituitary expand, ready for lactation. If the woman loses a lot of blood at the time of birth, they can undergo ischemia, die off, and then of course you have the issues further down the track with the hormones related to the pituitary. So if that's a scenario and she's, hypothyroid afterwards, think about Sheehan syndrome. Okay, antenatal care. So this is the whole care looking after women throughout their pregnancy. So pre-conception counselling, they should be taking folic acid for at least 3 months prior to falling pregnant. You want to cease smoking, normalise weight, update immunisations, because certain immunisations, such as rubella, can't be given during pregnancy. Booking visit, and this is potentially a quite common OSCE station, are things like you need to confirm the pregnancy. You need to work out whether it was planned or unplanned and how they're feeling about it. The date of the first day of the last menstrual period. You need to look at the characteristics of the normal menstrual cycle. So can you actually use that to predict their pregnancy? Any prior contraception, the date of the last pap smear, their obstetric history, so how many times they've fallen pregnant and how many live births they've had, what the outcomes of those were, whether there were complications in the delivery process, in the antenatal care, all of those sort of things, and then any of those sort of conditions that may occur again. In terms of dating the pregnancy, about 280 days. For most of the time, it's 9 months and 7 days, and most of the clinics will either have an app on their phone or will have one of those wheels that you spin around. The other way of dating it is by ultrasound. The younger, so from about 5 or 6 weeks on, you can date it. From then on to about 13 weeks is the most accurate. After 20 weeks, you then can't date it anymore. The growth varies too greatly between babies to make that any accurate. You use the crown rump length up until 13 weeks, and then you use the head circumference up till 20 weeks. Obstetrics is easy in terms of also the examination. For most of the time, it's essentially their weight and height and their sort of vitals, and then top to toe. So you would mention, you do a cardiovascular and respiratory examination. In an OSCE, you would mention a breast examination and a vaginal examination. Reality is you basically never do those unless there was an indication to do them, but just mention to say you've considered it. And of course, the abdominal examination will vary throughout the pregnancy, depending on what you need to do there. Investigations, and these you do need to know off by heart and be ready to rattle off in an OSCE. You've got things like your full blood count, your blood groups, of course, very important, whether they're rhesus positive or negative. You do a urinalysis for asymptomatic bacteria. Then there's their infectious screen, and all of these you screen for and test their resistance to or whether they're infected with it. Aneuploidy screening will cover, diabetes will cover, and then the dating ultrasound, as I've mentioned. The other thing to consider in an OSCE station would be potentially the common symptoms of pregnancy. So these are things like urinary frequency, fatigue, nausea, pelvic pain. Hyperemesis gravidarum is the severe form of nausea and vomiting. This is when women may actually need to come into the GP clinic if they can offer that, or hospital regularly for IV fluids. They can't keep any food down. So it's all about being able to counsel patients about those. Consider weight. They're not eating for two. For most women, a gain of about 10 to 13 kilograms is quite appropriate. But of course, if they've got a higher BMI to start with, you need to reduce that amount. it's not an excuse for the woman to go and eat, KFC every day because she's eating for two. Alcohol, of course, there's no safe level. The potential OSCE station, or part of an OSCE station, would be, a woman comes in and says, I've found out I'm pregnant and I've had a couple of drinks in the past few weeks. Reassure her, we're not sure of what the damage is, but just try not to continue on. And a lot of people will drink before they know that they're pregnant. Seatbelts still need to be worn. Air travel, exercise is appropriate and should be done throughout pregnancy. Work, for most occupations, you can work up until the time you deliver. Of course, if you're doing something manual, you may need to change that. And sex is not contraindicated at any point throughout the pregnancy. But of course, the woman's the desire for sex will fluctuate throughout the pregnancy. And then in the second and third trimesters, you look at the visit schedule. So initially, it's longer durations between visits. Then from about 28 weeks to 36 weeks, it's every fortnight. And from 36 weeks on, it's every week. You check on her health and well-being. You check on the baby's health and well-being. You do the investigations as necessary. Anti-D, for those women who are rhesus negative, is at 28 and 34 weeks. And you'll hear me hammer about anti-D throughout the lecture. Basically, any time you do any intervention, anything that may cause bleeding internally or that may allow the transfer of blood, you give anti-D. There's no real contraindication to giving it, so just give it. And an oral glucose tolerance test at 28 weeks for most women. Now, just quickly on multiple pregnancy, the terminology is the main thing to understand. And it depends on when the split happens as to what occurs. The main worry are the monoamnionic, monochorionic twins. So they're sharing exactly the same placenta and they're sharing the same amniotic sac. So what affects one will affect the other. If one declines, it'll often take the other one with it. So you need to consider that. And here, just for your reference, if it helps you understand, depending on when it divides, so the placenta, the amniotic sacs divide first and then the placenta is the result. You don't need to know that so much, but be aware that when you see it on in labour ward or you see it on an antenatal form, that you can interpret, okay, what does this actually mean? What do those words mean? And what's the significance of that? For multiple pregnancy, if they ask you about what risk to increase, basically everything is increased. And you need to be aware, of course, that there's increased risk of having complications at birth, preterm labour as well, but at the actual time of birth. So you need to do it in a tertiary centre, ideally, with senior members of staff there, making sure you've got 2 paediatric cots and 2 teams of paediatricians ready for resuscitation, all of those sort of things you'd mentioned. Twin-to-twin transfusion syndrome is probably the only issue that's isolated to multiple pregnancies that you need to know. This is between monochorionic twins. Essentially, there's a blood flow between the twins. And so one can get too much blood, one can get reduced blood. You get resulting polyhydramnios and oligohydramnios, so too much fluid in the amniotic sac and not enough. And this is fairly poorly treated. We can't do much about it, and it's often fatal for one or both twins. But that's probably the only one you need to know a little bit about. Okay, so the problems in early pregnancy. Early pregnancy bleeding is extremely common. So 60% of the women who do have early pregnancy bleeding will have an ongoing healthy pregnancy. 30% will have a pregnancy failure. So it is very common. Miscarriage is a station that I think from memory we had last year. So you need to counsel them. One miscarriage is absolutely common. It's normal. And so there's no increased risk of having miscarriages down the track. So counsel them about the fact that they can go back and have another try again, and there's nothing to worry about. The main differentials, of course, are ectopic pregnancy and miscarriage. So miscarriage, loss before 20 weeks. It's recurrent is only after 3 or more consecutive miscarriages, and most of the time it results from chromosomal abnormality. So it's nature's way, basically, and the body's way of saying this is just not going to work. So it miscarries. I'm not going to go through this, but you do need to be able to differentiate the different types of miscarriage based on whether, of course, there's bleeding, whether the cervix is open or closed, whether the fetus is still alive, and whether the products of conception have been passed. And this is a common multiple choice question. Of course, biochemically, you can determine by the fact that it's not present on ultrasound anymore and that the beta-HCG is either stalled or is falling. There's 3 types of management for a lot of the obstetric things. It's either expectant management, medical management, or surgical management. So expectant, again, anti-D, as always, and most of the expulsions occur in the first 2 weeks. Some take 3 to 4 weeks. Some of them may have already occurred by the time the woman realises that maybe the expulsion that actually causes her to realise she's had a miscarriage. Medical management, you can give misoprostol just to soften the cervix, or surgically you can go in and you can do a suction curettage. It's a blind procedure where you insert a suction instrument, remove the contents, and you can and then also sort of curettage to make sure you sort of scrape the endometrial lining clean of any products. Or you do a D&E if they're greater than 13 weeks, which is essentially the same procedure except that you have to dilate the cervix. So you give some medications to soften the cervix, you use some metal dilators gradually in size, and then go in with the suction device. And that's off prompt, just another way of representing that. By the way, down the bottom, I forgot to mention, but down the bottom, I have tried to put the prompt documents that are relevant to the areas. So if you're wanting further information, that's probably the documents to start with, and most of them are fairly easy when you search for them. Ectopic pregnancy is implantation of the fertilised egg in tissue that's not the endometrium of the uterine cavity. Most of the time it's in the fallopian tubes. It can, however, be anywhere within the abdominal cavity or the pelvic cavity, considering the ovaries are just floating within that space and the fallopian tubes are open. Risk factors are anything that disrupt the lining of the fallopian tubes. So if you've had previous pelvic inflammatory disease, previous surgery there, all of those things can disrupt that lining, make it scar, and make it more likely that the egg stops and implants there rather than going through to the uterus. You, of course, have a delayed period. You get pelvic pain and some abnormal bleeding. The signs are shock, abdominal guarding, peritonism, those sort of things. You're also looking on investigations for serum beta-HCG that rises slower than expected if the pregnancy was intrauterine. And you can also, of course, on ultrasound see that there's an empty uterus and either isolate it elsewhere or not see it at all, in which case you presume it's ectopic. Remember that every young woman, every sort of fertile woman is presumed to be pregnant until proven otherwise. Expectant management, basically if they're very stable, they live close to a hospital, you can do expectant management. It's generally not done. But it's basically monitoring the beta-HCG, hoping that this ectopic pregnancy will naturally fail. Medically, you can give methotrexate and, of course, anti-D. You check the beta-HCG and watch it fall. Methotrexate, of course, acts on rapidly dividing cells, so you need contraception for 3 months post-methotrexate use. Surgical management, you can do either a laparoscopic salpingectomy or salpingostomy. One is to remove the fallopian tube in which the ectopic pregnancy is located. The other one is is only used if you're trying to preserve the tube. Maybe they've already had the other one taken out. It's a much more difficult procedure. Essentially, you slit the fallopian tube open, try and remove the ectopic pregnancy, and then close the fallopian tube. But of course, in the process, you're doing damage to that lining, so there may be a risk of further ectopic pregnancies. And there's another diagram for those people who want to follow it through like a flowchart. Now, I'm just going to quickly touch on termination of pregnancy. It's unlikely you will be tested on it because because of the controversy and differing opinions and views. However, for your time on the wards, it is important because you may be present in a counselling session with a patient. Essentially, you can give mifepristone, which is this in the media RU486, and the woman can complete the termination at home. Of course, there are the complications of nausea, diarrhea, the heavy bleeding. Or surgically, you can do the same aspiration and curettage as you would do for a miscarriage. So it's there for your own information and for explanation if you do see a counselling session. It is useful to sit in on because it's a good opportunity to learn how the doctors do the counselling, which you may have to apply to a different setting within an OSCE, but the information's there. Okay, screening and diagnosis. So the major screening that you'll do is aneuploidy screen, and there's this combined first trimester test, which is still the recommended test. This is done between weeks 9 and 13, so it's got to be done by the end of week 13. You take the maternal age, you do a blood test. Beta HCG goes up because it's for an increased risk of Down syndrome or other aneuploidy. Beta HCG goes up because it is a pregnant state, so beta HCG would be up, and PAP-A goes down. You do need to know which way they go. So one goes up, one goes down, and the ultrasound scan. This is a risk. It's not a diagnosis, and you need to stress that in an OSCE, if you were counselling a patient, it's a risk. The risk varies between patients. One patient may say, well, 1 in 100 risk means there's a 99% chance I'm unaffected, which is fine. For someone else, a 1 in 300 risk is really high and they want some more invasive testing done. Second trimester screening is only done if the first trimester screening hasn't been done because the woman's presented late. And you do measure for 4 blood markers. Beta HCG, so the second two, beta HCG and unconjugated estradiol, so number 2 and 4 in that order, or in alphabetic order, they go up. The third 1 and 3 go down. That's how I've remembered it. You do need to know which way they go. And that's for an increased risk. You do a 20-week ultrasound just as a normal part of the antenatal care, but this is not included in the actual calculation for risk. The NIPT test, or the Harmony test, is the maternal blood test that is done where they can find cell-free fetal DNA in the mother's blood and then use that as a way of determining risk. That's fairly new, but is increasingly being used and offered by clinics and hospitals. Invasive diagnostic test, the earlier you do it, the higher the risk of miscarriage. So CVS from 11 weeks onwards, amniocentesis, sampling the fluid, is from 15 weeks onwards. The advantage is the chorionic villus sampling is earlier, so the woman may not be showing. So if she has had a diagnosis of trisomy 21 and wants to have a termination of pregnancy, she may not be showing, so no one else knows she's pregnant, so there's a benefit there. However, it's got a higher risk of miscarriage. Of course, anti-D because it's an invasive procedure. Imaging obstetrics is fairly easy. It's essentially ultrasound, but you do need to know a little bit about it. You don't need to know how to interpret an ultrasound or what, but you do need to be able to work out, okay, what does it mean? So anything that causes oligohydramnios or polyhydramnios is not normal. There shouldn't be too much or too little fluid. Think about the way, of course, the baby is in this sac, it drinks the fluid and then it urinates the fluid out. So if its kidneys have shut down and it's not urinating, then it's drinking, but it's not urinating anything else. So you've got decreased fluid. Think about it like that. Cervical length is important. You'll often hear women talking about a short cervix. And this is essentially where women who have a shorter cervix, as the pregnancy goes on, and especially just before delivery, the cervix shortens and then effaces. And so, of course, if you've got a shorter cervix, you've got less room to play with. And so a lot of these women will have early delivery. And then using ultrasound, you can do Dopplers. So you look at, and it's an ever-increasing list of arteries that you can look at, but you're looking for the flow through those arteries, working out whether they're dilated. So if the baby's hypoxic, the things like the MCA will dilate to send blood preferentially to the brain. So again, it's working out, okay, what might these mean? You don't need to be actually able to interpret them. CTGs, however, you do need to interpret. For people like me who struggle with ECGs, they're much easier. There's generally only 2 lines and there's none of the PQ waves. Cardiac behavior for the baby is like in adults. It's a mixture between the sympathetic, the parasympathetic system and all the various other mechanisms. So it does vary and that's normal. You do need to know the definition. So baseline rate, which is just where roughly it's sitting, is about 110 to 160. Baseline variability, so this is the individual fluctuations across the minutes up and down, is between 6 and 25. The acceleration, so you should have 2 accelerations, and these are greater than 15 beats above the baseline for 15 seconds. And you should have 2 of those within a 20-minute trace. And decelerations, which are 15 beats or more down from the baseline and for 15 seconds or more, you shouldn't have any of those in a normal healthy trace. The picture up here, essentially you've got one monitor which is looking at the uterine activity of the mother, so working out when there are the contractions, and the other one's placed to find the baby's heart rate. In terms of, so baseline fetal heart rate, tachycardia, the two big ones for both were tachy and bradycardia, hypoxia. There are other causes in the notes. The rule of threes is important in terms of obstetric emergencies, and if you've ever seen an obstetric emergency, it's a model of efficiency basically, in terms of that all the staff know exactly how the system works to get the mother from labour ward down to theatre, the lifts that work only for the inner code green, which is an obstetric emergency. So basically from 0 to 3 minutes, if there's bradycardia, you've got 3 minutes to reverse the causes 3 minutes if bradycardia has existed for 3 minutes, you need to call for help. From 3 minutes to 6 minutes, that's the 3 minutes you've got to reverse those causes. And then from 6 to 9 minutes is basically, okay, we've got to bail this baby out. So that's the time when you get them down to theatre and it's a quick emergency caesarean section. The variability, as we've mentioned, is a fluctuation, absent and reduced or increased. Now, when a baby sleeps, it will naturally have reduced variability. So if you see that in a trace, what you want to do is say, right, can we look back 20 minutes or look in the next 20 minutes and see whether it returns? So babies sleep for about 20 to 30 minutes at a time in the uterus. So they should, after 30 minutes, it should go back to normal. And if that happens, you can be reassured and just say, okay, baby's sleeping. But that's a common question also the consultants will show you is a normal trace and then there's a period of decreased variability. And then you can say, okay, look, probably the baby's sleeping because it's then returned to normal. Accelerations, as I've said, 15 beats per minute for 15 seconds, and they're normal. Decelerations are a whole lot of different types, and there's information in the notes there. You don't need to know the different types. You just need to know that that is a deceleration and that's not normal. And so that's a sign that baby's not happy. So this is a normal trace. You've got a baseline rate of about 135. You've got good variability. You've got accelerations, which are helpfully marked by the A's, and you've got no decelerations. So that's normal. Down the bottom, you've got the maternal uterine activity, which is basically at the moment doing nothing. What you'll see in contractions is big, almost like the accelerations for the baby's trace, big ups and then back down again. And so you can see how often the woman's contracting and whether they're good contractions or whether they're not. At the moment, she's not doing anything, and that's probably just a pre-labor state. This is an abnormal trace. So this has reduced variability. It's got a good baseline heart rate, reduced variability. There are no accelerations and there are significant decelerations. And so this is a baby that's not happy. The other thing you can use, the combination of CTG and the ultrasound, is to look at the biophysical profile. Now, most of the time you'll hear this mentioned. It's not done a lot. It's often done to reassure clinicians about about the baby's health. It's essentially looking at various other factors of the ultrasound: breathing movements, body movements, tone, and the amniotic fluid volume, and combining that with a CTG. Now, infections in pregnancy, I'm going to go over fairly quickly. Most of it is buzzwords. Most of it is an understanding that you can either have infections that cause teratogenesis, that actually affect the baby, or you can have infections that cause problems for the mother, which may then lead to problems in the baby. The time frame, from 0 to 2 weeks, it's basically all or nothing. So if there's an insult during that time frame, it's likely that there will be a miscarriage. The woman will never have known that she's pregnant. It'll just be a normal menstrual cycle, and that's how the baby protects against it. The time of vulnerability is 3 to 8 weeks, and that's where all of the main organs lay their foundations. And so that's the time when infection during that period is likely to have consequences down the track. And 9 to 40 weeks, as the pregnancy goes on, the baby becomes more and more resistant to the infections, I suppose, like humans, like children to adults. Influenza, particularly relevant at this time of year. Mothers can be vaccinated, should be vaccinated, and it's not particularly harmful to the baby. It's more the problems caused by a severe fever that may cause early labour. Urinary tract infections, you do screen for asymptomatic bacteria regularly throughout pregnancy, generally at booking and at about 28 weeks. But again, if there are symptoms. The main thing to remember are the certain medications you can't give for urinary tract infection, but cefalexin or amoxicillin are absolutely fine. They're at an increased risk because they get progesterone-mediated relaxation of the smooth muscles, so you get urinary stasis, you get increased risk of infection. Something just to warn women about as well if they get symptoms. Rubella, the buzzwords are this blueberry muffin rash and cataracts in the baby after birth. It's highly teratogenic if it occurs early in the pregnancy, and 100% of infants infected in the first 11 weeks will have this congenital rubella syndrome. Essentially, in the mother, it's a mild illness, but in the baby, of course, it's very significant. And if there's maternal infection confirmed in the first 12 weeks, you offer a termination because of the 100% transfer. Chlamydia and gonorrhea are not that important in terms of the actual pregnancy. They're more things you screen for initially. Remember that, of course, short term, they cause the urinary tract infection kind of symptoms. Longer term, especially for chlamydia, they can cause pelvic inflammatory disease, infertility, ectopic pregnancy. During the pregnancy, for mum, it can cause things like miscarriage or a preterm birth. Afterwards, it can cause, in the baby, of course, preterm birth, growth restriction, those sort of things. You test women, as we've said, but most of the time it's very easy to treat. For cytomegalovirus, sensorineural hearing loss is the buzzword. These commonly are used in MCQs, overlap between paediatrics and obstetrics. Where they fall varies between each year in terms of the actual marks. They're probably the main things. I'm going to skip through these because the notes are there for you guys. Parvovirus causes this fetal loss and hydrops fetalis before 20 weeks, and that's the sort of the buzzwords. Remember, of course, that you need to know about parvovirus for paediatrics and in GP. The risk, you can see there, markedly decreases after 20 weeks, the risk of transmission to the baby. There's no maternal treatment or vaccine available. So really it's about counselling the woman, saying, look, the risk is fairly minimal that it goes onto your baby. We'll monitor your baby. We'll make sure we do the tests on the baby, etc. For chickenpox, you get this congenital varicella syndrome, and this gives this classic buzzwords of the skin lesions, limb hyperplasia, microcephaly, and ophthalmic lesions. Most women, of course, will be immune. You can give them a booster shot prior to pregnancy if they weren't. You can also give zoster immunoglobulin if the time from exposure is short enough. Again, these are things to warn women about if they're having symptoms, especially since most women who are having babies will be interacting with younger kids as well. Syphilis, of course, is that painless ulcer in the genital area. You screen for it at booking. It's so easy to treat, it really shouldn't be missed. Easily treated with penicillin. Toxoplasmosis is, I reckon, is a wonderful parasite. For those who don't know, it essentially it goes between the rat and the cat. And when it infects the rat, makes the rat attracted to cat urine, which therefore means the rat is less scared of the cat and therefore completes the cycle. For women who have cats, most cats will probably have toxoplasmosis. Casual interactions with a cat are not an issue. So if you've got a cat at home, that's fine. You can still pat them. You can still be in the same house. What they advise women to do is prevent. Prevention is in terms of don't handle the cat litter, so get someone else to do that. Make sure you wash your hands thoroughly, keep the cat off the cooking surfaces, make sure you cook your meat well, those sort of prevention. But having a cat in the house is basically not a risk. And it causes this chorioretinitis, the neurological consequences, and hearing deficits. Listeria, again, recent outbreak in the air conditioning coolers. This is the one where you advise women to avoid soft cheeses, pre-prepared salads, uncooked seafood and stuff, but it's very rare and it's very easily treatable. Group B streptococcus. Now, depending on which hospital you're at, you have different recommendations. Some hospitals screen every patient for GBS. Other hospitals only screen at about 36 weeks of those women who are deemed as high risk. And GBS is the main one you need to think about for women who've had a prolonged rupture of membranes or a prolonged labour or temperature during labour. That's the main thing you're worried about is the transmission of GBS and its implications. A lot of the time, I think I've put the wrong buzzword in at the top. Because I was about to say that most of the time it's a sort of commensal organism often of the mother. So they'll basically be asymptomatic, which is why you're screening for it. So I'll change that when I upload it, but ignore the top buzzword. It's probably where the buzzword should have gone. Herpes is very easily treatable and causes neonatal infection, encephalitis, and death. So encephalitis is one of the buzzwords for herpes simplex. Chorioamnionitis is basically any infection of the so of the placenta and the amniotic sac, and causes maternal fever. And again, broad spectrum antibiotics are very easily treated. HIV is potentially a station that they'll give you as a counselling station, both in terms of the tests, so going back to third year, testing your sort of the pre-test counselling, your post-test counselling, but also, and then for obstetrics, how to reduce transmission. So treating HIV positive women with antiretroviral therapy, treating the baby, making sure you avoid breastfeeding. It's one of the only times you should avoid breastfeeding. You consider elective cesarean basically in most women, regardless of their viral load. You avoid interventions like fetal scalp sampling, so taking sort of samples from the baby's head during labour, and avoid rupturing the membranes. All about reducing transmission. And then just a couple of others. Hepatitis B and C refer to infectious diseases, and gonorrhea is more for gynecology, just to keep in mind. Okay, so we'll move on to medical disorders in pregnancy. So there are a couple of different categories of hypertension. Hypertension itself, gestational hypertension, is new hypertension arising after 20 weeks in pregnancy, and that's it. So if you want, for the definition of preeclampsia, you take that hypertension and you add some end organ damage on top. So kidney, liver, neurological changes, increased tone, clonus, hematological changes, and fetal changes, so babies in distress. And then for eclampsia, you take the hypertension, you take the end organ damage, and you add on convulsions. So think about it in that framework. Chronic hypertension, of course, women can be hypertensive before pregnancy, just like they can have diabetes before pregnancy. So preeclampsia is a placental disorder. So you can't cure it until you get rid of the placenta. So basically, the way to cure it is to deliver. Presentation is classically, of course, the high blood pressure, and then they can get things like headaches, visual disturbances, epigastric or right upper quadrant pain from the liver. They can get reduced renal output. They can get lower abdominal pain, bleeding if there's compromise to the placenta. For examination, you do need to look for clonus and hyperreflexia in particular. And really, there's no good way of preventing it. Aspirin may help, may not. Most of the time, there's no good prevention. It's about how you manage it. Risk factors, first pregnancy with that particular partner. So if you've had 3 children with the same partner, your risk decreases for each one. If you then have a new partner for the 4th child, you go back to the original risk. Of course, all the other things, like you would in any station where you don't know anything about risk factors, is, overweight, smoking, older, that kind of thing. Maternal assessment, blood pressure, of course. Look for proteinuria as a sign of renal end organ damage. Look for hematological changes, and look for liver changes. Fetal assessment is essentially you do a CTG and an ultrasound if necessary to check baby's well-being. Okay, so hypertension management just by itself, forgetting the preeclampsia, hypertension just by itself has definitions. For mild and moderate, you use basically oral drugs, and they can be sent home. And you do pick one and remember it, because you will need to know one. For severe hypertension, you bring them into hospital, you give them 2 large bore cannulas, you give them a fluid bolus before you give the antihypertensive. Now that sounds a little bit, you're giving them more, initially you're going to up their pressure, but it's only for about 15 minutes before you give the antihypertensive. What you want to try and avoid is having hypotension and having that compromise the blood supply to the baby. So you give the fluid bolus initially, and then you give the antihypertensive medications. At the same time, you give magnesium sulfate as a prevention for eclampsia, for seizures. Preeclampsia, you manage the hypertension as we've just gone through. And then you manage the preeclampsia side of things. So in an OSCE, admit every woman today, no exceptions. Reality is you wouldn't do that, but for an OSCE, say, no, you've got to come into hospital. You monitor them regularly. If the baby's under 34 weeks, you give betamethasone. So this is 11.4 milligrams IM. You give 2 doses 24 hours apart. And the idea of this is it's a steroid to help mature the baby's lungs. So you try and buy yourself that 48 hours to mature the baby's lungs if you're thinking birth is imminent. If they're after 37 weeks, so 37 weeks to 40 weeks is technically term, there's really no benefit to them being for the baby still to be in the uterus. So at that point, you expedite delivery, get the baby out, and solve all the problems. Eclampsia management. Main thing to remember here is A, magnesium sulfate is good for prevention and treatment, and B, that 30% of seizures occur postnatally. So you need to be conscious of that if you're managing a patient, that it's not just, okay, the hypertension's fixed, yes, when the placenta's delivered, but the seizures may still occur afterwards. Okay, so gestational diabetes is essentially diabetes that occurs during pregnancy and is not type 1 or type 2 that's already been existing. Risks are like most of things for diabetes, and it occurs because you get increased insulin requirements throughout pregnancy, and you get insulin resistance that's peaking at about 28 or 30 weeks. So there'll be a lot of women who have gestational diabetes, who may not have diabetes before or after the pregnancy, but may be at risk of developing diabetes down the track. So it's a good marker for GPs kind of thing to say, okay, that we need to manage this better once you've had your pregnancy. Fetal complications. The main one of note is macrosomia. So this is there's increased glucose around, baby grows more, is a heavier baby, and that causes problems at the time of birth, and such as shoulder dystocia, which we'll go into. You do need to know these definitions. So overt diabetes is exactly the same definitions as you would be learning for GP, 7 and 11.1. For gestational diabetes, there are different definitions. The reason for this is basically, I think that they're not really sure at what point you should be classifying it, and B, the risk starts to increase after those values, so they are different from your everyday, from your overt diabetes. You offer a random blood glucose at booking visit. If that's normal, then you do an OGTT at basically 28 weeks. If it's abnormal, you do an OGT then and there at the booking visit, and then refer them whenever necessary to the diabetes services. Management, of course, your multidisciplinary team, education, self-monitoring, diet, exercise, and your targets. You still use mainly insulin. There is an increasing use of oral hypoglycemics, but mainstay of treatment is insulin for these women. And of course, you monitor the mother. This is in here because this is in the prompt guidelines, and it varies between clinician, but basically if their diet are under 20 units of insulin a day, they're seen as non-diabetic, so you just continue normal pregnancy care. If it's greater than 20 units, you do increased monitoring, so you increase CTGs and ultrasounds, you consider different styles of delivery, those sort of things. So in terms of delivery, if the baby's large, so if you're thinking that the baby's going to be 4.5 kilograms or more, in that case, you're thinking, okay, maybe we need to do an elective cesarean rather than a vaginal delivery. And then after pregnancy, you reduce the insulin dose back to pre-pregnancy levels. So if they develop gestational diabetes, they weren't previously taking insulin, so it goes back down to none. Thromboembolism, hypercoagulable state, revised from third year, essentially. And the thing to remember also is that 30 to 50% of them occur after the pregnancy, so in the 6 weeks following. So monitor them, be very conscious that if a woman comes in with shortness of breath, with of course calf pain kind of thing, that's when and she's pregnant, that DVT or PE rises up the list, even though in a younger woman, otherwise you may not think of it as acutely as other things. And remember, of course, no warfarin because it's teratogenic. The other condition that you should know about is cholestasis of pregnancy. This is essentially where you get pruritus, especially in the hands and the soles of the feet. in the absence of any skin rash. Jaundice is rare, and you look at the LFTs and the serum fasting bile salts generally, and they'll be abnormal. You monitor the mother regularly. There's really not much you can do about it, again, until delivery. You can give ursodeoxycholic acid. Vitamin K as well is potentially quite beneficial. And then all your symptomatic relief that if you haven't done GP yet, you will learn about when you do dermatology. Your calamine lotions, your cool baths, you're wearing light clothing, not overheating, all of those sort of things. So that's more a sort of buzzword condition, itchiness of the palms and soles of the feet without any rash, without any jaundice necessarily. And then just decreased fetal movements. Very important to take in account to what the mother says. So mother knows her baby. There is no right or wrong amount of movements. It's what's usual for that particular baby. And if they're reported to be decreased, it's something you should always ask about. If it's reported to be decreased, you then need to go investigate. So initially, of course, you'd do an examination, you'd feel baby's growth, make sure that it's still growing normally, do a handheld Doppler, and then you do a CGG and ultrasound if you are still concerned. Only at that point, if everything else is normal, can you say to the mother, look, we're not, we accept that you're having reduced movements, but everything looks to be normal from here. Make sure you come back to us tomorrow or the day after if it's still abnormal, and we'll measure everything again. Don't write off the mother's her experience, her findings. Don't write those off because they're very important, and the mum, of course, knows how her baby moves. Okay, so labour and delivery. Do people want a break, or are you happy to keep going? Let's get it done. All right. Jump in with any questions, of course. For those people that find anatomy study difficult, this is the only bit of anatomy you actually need to know for fourth year is the pelvic anatomy. And of course, only for the woman, but you do need to know it in a bit of depth. And you need to be able to adapt it to what you're seeing. So you need to be able to describe, okay, in a Caesar, what am I doing? Potential oscillatory station is, okay, take us through a Caesar. What layers are you moving through? Whereabouts in the uterus are you going into? What blood supply is it receiving? What might be at risk of bleeding, etc. So I've just put a couple of diagrams on there. So when you go back over these slides, if you do, is to think about, okay, I've got to know my anatomy. Labour and delivery is basically a combination of the three P's: the passenger, so the baby, the passage, which is the pelvis, and the power, which is the other uterine contractions. And you can see that if a baby is delivering like it should, which is a well-flexed baby, then you've got a measurement of about 9.5 centimetres, which is easily going to fit through all of those areas, the inlet, the mid-pelvis, and the atlet. As the baby becomes less flexed in its head, it of course increases up to 13 centimetres, which means it's going to have issues. So that's just something to consider. There are ways you describe the baby when you're examining, and this is in an abdominal examination, you describe the baby. So you describe the fetal line. So this is the long axis of the baby in comparison to the long axis of the mother. So is it longitudinal up and down, or is it transverse across, or is it oblique at another angle? You describe the engagement of the baby. So this is how much of the head can be felt above the pelvic brim. So what you're basically doing is, as the baby descends into the pelvis, you can't no longer feel it because the bone's are in the way. So what you're trying to do is work out how much of the head do I think is out of the pelvis. And that's what people are talking about when they say the baby drops just before labour, is that it's starting to move down into the pelvis. You won't be expected to actually give accurate measurements, but these are things you would comment on when you're doing your examinations. Symphysial-fundal height is measured from the pubic symphysis to the top of the fundus and should be within about 3 centimetres of the gestation in weeks. Make sure, especially in an examination, not so much applicable for OSCEs, but for those who haven't done obstetrics, make sure you're able to locate your own pubic symphysis, and so you know where it is, because otherwise it becomes incredibly awkward for the woman if you're trying to find where it is, and you're also going to get measurements that are completely wrong, because you're going to find you have 27 centimetres in a woman of 34 weeks. So make sure you're able to work out exactly where that is, know where it is, and then measure from there. Macrosomia is a large baby, so greater than 4.5 kilograms. And so it's large for gestational age in terms of you're only estimating the fetal weight. You've got no idea, of course, until it's delivered, but you're estimating. Risks, of course, familial, ethnicity, maternal diabetes or obesity, and congenital abnormalities. Most of the time, these women can have an uncomplicated delivery. It's just a normal, larger baby. But for women who don't have diabetes, from about 5 kilos on, you consider an elective Caesar. And for women with diabetes, as we've said, 4.5 kilos and upwards. Small for gestational age is below the 10th percentile. Again, these babies can be normal if they just fall in that last 10%. Where you get fetal growth restriction is when you've got a baby that's small and there are problems associated that are either causing that small for gestational age or that are contributing to it. So these are things like erratic growth, hemodynamic compromise. Again, you monitor and you talk to the paediatricians and work out whether you need to deliver. And it's all about working out the benefits versus the risk. Do we deliver the baby at 28 weeks and say that, okay, it's too early, or are the risks too great of doing that? Fetal position. This is, and again, you'll hear this described in labour ward. So this is looking at where the denominator, so the baby's occiput, is in relation to the maternal pelvis. So if it's occiput posterior, means that baby's basically, if mum's lying on her back, baby's lying on her back as well, looking up the same way, because the occiput is down towards the back of the mum. Flip that round, occiput anterior means baby's head is facing up and baby's looking down into the bed. So those are words that you'll need to be able to understand the significance of. Presentation is essentially which part of the baby is coming first. Cephalic is what we want, head first. It can be a shoulder potentially, or it can be breech. And there are various classifications of breech. Frank breech is the knees are extended. Incomplete breech, the knees are flexed. And then footling breech is obviously the foot is coming through. Management depends on what type of breech it is. You can try external cephalic version. So this is done at about 37 weeks. This is very painful for the woman, and so you do have to warn her of that. Essentially, you lie her down and you try and with your hands and an ultrasound machine to guide you is try and move the baby around from externally. So you can understand it's obviously very difficult and a lot of pressure required, especially at 37 weeks when there's not a great deal of room in the uterus anyway. That works in about 50% of the time if you're an experienced clinician. You can do a vaginal breech delivery for those who are frank or complete breech, not in footling. They'll talk about a hands-off procedure. So the more intervention you do, more hands-on you try and guide the baby out, the more problems you cause. And if that's not working, of course, you go straight to a cesarean. Now, this video you can easily find online. It'll hopefully be in the slides when they're uploaded. Goes through how the baby descends into the pelvis, engages, flexes and rotates, and then extends and restitutes as the head comes out, and then the shoulders and body come out. Probably a good idea just to have those steps in your mind so that you could explain it if you were given like this a model and asked to explain. There are 3 stages of labour, and each of them are broken down a little bit more. So the first is commencement of the contractions through to full dilatation at 10 centimetres. Second stage is from that full dilatation to the delivery of the infant, and the last stage is the delivery of the placenta. If you haven't already been on Women's, or if you have, go grab a partogram, the paper copies. Some hospitals now use electronic, but grab a paper copy, be able to interpret it, be able to work out how the nurses write and document stuff in there, because it does come up as MCQ questions regularly in exams, like last year, and you will have to be able to interpret it. They could also give it to you in an OSCE and say, could you please interpret it? You know, what's the management? What's the issue? What's the problem? So the first stage of labour is you've got a latent phase. So this is where women haven't had regular contractions yet. They're feeling a bit niggly. They may ring up the hospital. They may present a couple of times. Send them back home. Let them stay at home. Rest, hydration, food, because they're going to have a tough time coming up. Then the contractions become regular at about 4 centimetres through to about 10 centimetres. They're well established. The cervix starts to dilate. And then there's this transition phase that isn't technically a phase, but that most midwives will talk about, which is when suddenly you've got this rational woman who doesn't want pain control, and suddenly she becomes irrational. She's yelling at her husband. she wants an epidural, all of those things. And that's when often she's transitioning from being fully dilated into the second stage. In the first stage, you try and you minimize the interventions. You do 4-hourly temperature and BP. You offer analgesia. You get the woman to move around. You get her to eat and drink if she can. And you check the baby intermittently. It's often a great time in labour ward, if you're there for that, to build up a relationship with the patient and the midwife, because there's not much else happening. So you need to know the definitions of delay, which also vary between hospitals, but go with the ones from Monash. And basically what you're trying to do is positive encouragement, change position, fluids, empty bladder, go have water immersion, be on one of those exercise balls, and just wait and see. In the second stage, you've got a passive phase, which is just the baby's natural descent down into the birth canal, and then the active phase, which is where, of course, mum's pushing with the contractions. Mean length is about an hour in first pregnancy and 20 minutes after that. You do more frequent monitoring. You make sure you intermittently auscultating the baby, basically every 15 minutes, but you do it between contractions, or basically after each contraction, making sure the baby is coping well with the contractions, which of course reduce blood supply to the baby. So it's quite natural that the baby will have a deceleration during that period associated with a contraction, and then it jumps back and you go, okay, baby's responding well to that contraction. Again, you can consider augmentation with oxytocin. So this is synthetic or syntocinon, to try and help the uterus to contract in a regulated and strong way. Watch out in oxytocin in anyone who has had a previous pregnancy, purely because what you're looking at is, if there's a delay in a woman who's previously had a normal vaginal birth, you know that the passage is fine. So you've got to be, and that the uterus can contract in a regular, proper way. So what you want to do, you've got to be careful in both, but what you want to do is you want to make sure that you're not giving women oxytocin and just upping and upping and upping it if you're not sure of why there's a delay. And then third stage is the delivery of the placenta. So the baby's out. There are two ways of management. Active is the way you should do it. Physiological is the way that that medical science doesn't necessarily recommend. Active, you're giving a uterotonic agent as the shoulder is delivered or as the baby's delivered. Sometimes it all happens in one. You do controlled cord traction, which is basically as the woman has a contraction, you pull on the cord gently to try and get the placenta out. At the same time, guarding the uterus. So you're putting pressure on the uterus to stop the uterus inverting and coming out with the placenta. And it should be delivered within 30 minutes. If there's a delay, so if it's not delivered after 30 minutes, you just keep doing the same thing, empty the bladder, make sure you've got IV access, and then otherwise prepare for a manual removal under anaesthesia in theatre. So that can actually be quite, can be local anaesthesia. If they've got an epidural in, that's fine. And they can still be with the baby. It's not necessarily an emergency. It's more just you need to get it out because it's a foreign body then. Pain management in labour. Look, there's more detail in the notes, but essentially that's the ladder that you'd go through. Emotional support, water immersion, touch and massage. Your sterile water injections going to the back. Apparently they're really painful, and the idea is just that they take the pain focus away from what's happening to the back. I don't understand the logic, but they're often used. Your narcotics, of course. Your nitrous oxide gas is often used just as a way of getting women through it, but they're still quite rational with it. And of course, an epidural. But the epidural has limitations on bladder control, on being able to walk around, so you do need to counsel them if they're going down that track. Prolonged pregnancy is greater than 40 weeks. Initially, you just watch and see. You can do a membrane sweep, which is literally just running your finger across the membranes, just to see if that stimulates labour. You make sure you monitor them. And then you do an induction of labour at close to 42 weeks, because the risks after that rapidly increase. To do an induction of labour, you need to calculate a Bishop's score, which essentially is looking at how favourable is the cervix. Unfavourable is under 6. Favourable is greater than 6 or equal to. If it's unfavourable, basically what you do is you give some prostaglandins to try and make it favourable. And then once it is favourable, You can do amniotomy if the membranes haven't ruptured yet. So it's essentially where there are various mechanisms, but it's either a hook or an alligator clip. You basically try and break those membranes, which then helps to stimulate the labour, and you can then put up oxytocin. Of course, if the if the normal delivery doesn't work, you need to do you need to do some instrumental delivery or a cesarean. You do need to know these. So safe instrumental delivery requires the cervix has to be fully dilated. The head has to be fully engaged. You need to know the position of the head as you're applying the instruments. You need to empty the bladder, and it should be pain-free, as in you need to give appropriate analgesia. There, you've got either a ventouse, which is essentially like a little suction cap that gets put onto the baby's head and sucks the baby and suctions on and then gives you traction like that. Or you can use forceps, and there are a variety of different forceps that you can use. You can use the Wrigley's forceps, which have a shorter handle and often used as a shoehorn in a cesarean to help the baby out, or just as the baby's on the view to get the final bit. You've got your Neville-Barnes forceps, which are more at your mid cavity, and then your Kielan's forceps, which are for rotation of the baby. You don't need to know too much about these, but it's useful to be able to be aware of what they do when you're in labour ward. Complications, of course, you're adding instruments into an already tight space, so you can cause lacerations and tears. You can cause to the baby, you can cause fetal bruising or forceps marks. These are often temporary, and just reassure the mother about them. But you can cause more serious complications such as skull fractures, retinal hemorrhages, and cephalomatomas as well. To mitigate the risk of a tear, you often do an episiotomy, and the idea is to enlarge the outlet. There are two different types. You can either do a midline, which is preferred in the US. We prefer a mediolateral cut. Mediolateral cuts it takes a longer time to heal and more likely to bleed. But if a tear occurs and it extends down the mediolateral line, it's more likely to go away from the anal sphincter. So that's what you're trying to protect. If you do a midline tear, it's going straight towards the anal sphincter, and that's not ideal. So regardless, of course, whether you do an episiotomy or not, you can have perineal trauma, and there are 4 degrees. And it's basically how deep does the tear go. So if it's just the skin, it's 1st degree. If it involves the perineal muscles, it's a 2nd degree. If it goes through to the anal sphincter muscles, it's a 3rd degree. And if it goes all the way through the rectal mucosa, it's a 4th degree. 3rd and 4th degrees are obviously extremely serious. They have implications on long-term continence. So you need to, they have to have antibiotics, which we'll go into. B, they need to be properly fixed in theatre, and then they need to be sent to continence clinics afterwards, all of which I think I've just said there. And you also give things, often after repairs, you give paracetamol and NSAID suppositories, rest, ice, kind of thing, and stool softening laxatives just to help things. Repair is essentially very easy. You work inside out of the layers and work your way back out. Often a really good time to go through the anatomy as well, because the doctors will sit and do the repair, and you can often talk to them about the anatomy, and they can show you in a bit more depth. And of course, a cesarean, you can either do elective or emergency. Generally these days they do a lower segment cut, and you need to think about the implications from any operation on the mother, but also potentially the fetal implications, whether does it cause an increased risk of conditions because they're not going through the birth canal, and that's really yet to be conclusively seen either way. Post-operatively, you may have to write post-op instructions in an OSCE, so remember your intervals of monitoring, initially almost 15-minutely, then going out to an hour, then out to 4-hourly. Pain management and sedation, your vitals, making sure they've got appropriate fluids, but they're also having an appropriate urine output, and then looking at the wound and the surgical site. And then there's this concept of VBAC, which is vaginal birth after cesarean, which you'll hear spoken about. The idea being that once you've had one cesarean, you've interrupted the muscle of the uterus, and therefore there's an area of scar tissue there, an area that is weaker, and so it may not be able to contract in the same way as it should if you hadn't had a cesarean. Generally, they say after 3 or more cesareans, you can't have a VBAC, but of course the individual clinicians will differ with those, and that's just because at the moment they feel like you're more likely to have uterine rupture, which is going to be even worse because that basically means you have to do a hysterectomy and can't have any future children. All right, so emergencies, and we're getting through it, so we'll hopefully be done by about 7:30. So is everyone right to keep going? All right, perfect. Now, emergencies, this is also going to go a little bit quicker. There is a lot of information on these slides because you do need to know the steps and you do need to be able to rattle them off in an OSCE. And that's why I say start practicing OSCEs now, because you do need to be able to walk into a station and say, okay, it's postpartum hemorrhage. I know exactly what I need to do. I need to take a quick history, make sure she's conscious, make sure, and then I call for help, and then bang into medical management, bang, what are the causes, bang, what is the surgical management. So these are the type of things that you should be starting to practice and make sure you've got your head around, and also that you can jump from bits. If they say, okay, medical management's done, start at surgical management, you can jump between. So the main managements are, main emergencies are, so of course you've got the unfortunate deaths that occur. The emergencies are your postpartum hemorrhage, 500 ml of blood loss or more, which for most surgeons would be catastrophic, but if in a normal delivery you have 400 ml of blood loss, you're actually still under normal. Placental abruption, which is where the placenta separates from the wall of the uterus. Shoulders dystocia, which is where the shoulders get stuck. And cord prolapse, which is obviously where the cord prolapses. Resuscitation is exactly the same as in any other patient. Remember, left lateral tilt in the mother. And the other thing is that if resuscitation isn't successful in about 4 minutes, you should be doing an immediate cesarean section and getting the baby out by 5 minutes. The other thing is that the welfare of the mother does take precedence over the baby, rightly or wrongly on personal views, but that is the case. That very rarely applies though. Like you very rarely ever have to employ that. So antepartum hemorrhage is bleeding from the genital tract after 20 weeks. Most of the time it's placental abruption, otherwise placenta previa or accreta, and all women should seek medical attention. So placental abruption, the placenta separates from the uterus. You get this PV bleeding, you get abdominal pain, you get tenderness on palpation. Of course, you can get potential compromises of the baby as well. And you get different types of placental abruption. So you can get a concealed abruption. So that's where the placenta is still attached down towards the cervix, and therefore the bleeding happens within the uterus but doesn't track out of the cervix, and so there's no obvious bleeding. There's revealed abruption, which is obviously where the bleeding is present, and then there's complete, which is where the entire placenta separates and basically the baby is no longer viable. You do CTG monitoring and you do a Kleihauer test. For the smaller bleeds, often you just make sure that there's hasn't been too much transfer of baby's blood into the maternal blood, and of course anti-D. Placenta previa is where the placenta implants into the lower segment of the uterus. Now, most placentas do implant towards the lower segment of the uterus. As the pregnancy increases, the lower segment basically expands, and the placenta seems to track. It looks like it tracks up towards the top of the uterus. So most low-lying placentas will actually be fine by the time you get to the 3rd trimester. It's painless PV bleeding in the 3rd trimester. 1 and 2 are grades 1 and 2 are considered mild. Grades 3 and 4 are when they're either partially or completely covering the os, and they're serious. And of course, you can't have a normal vaginal delivery with that because the placenta's in the way. The baby's never going to get out. Placenta accreta, increta, and percreta is essentially stages of invasion of the placenta into the uterine wall. So remember, the placenta naturally has to invade the endometrium. It has to do that at the start. If it goes too far, however, you can get accreta into the uterine wall. If it goes through the muscle, it's increta. And if it goes all the way through the muscle into the serosa on the sort of pelvic abdominal side of the uterus and into other organs, you get percreta. For management, if you detect this early on, so this may be a reason why the placenta, the 3rd stage fails to occur as it should. If you detect it beforehand, you need ICU facilities, blood bank, radiology. Most of the time, you're going to say it's a cesarean hysterectomy, unfortunately. So you would take the baby out, and then you'd have to remove the uterus as well. Vasa previa, as opposed to placenta previa. Vasa previa is where the fetal blood vessels run along the amniotic membranes and across the os. And so any bleeding from that is therefore baby's blood and is not maternal blood. Now, baby at term has about 100 ml of blood per kilogram. So normal birth of 3 or 4 kilograms. It's not a lot of blood to lose before baby's lost it too much and then suffers. So most of the time it's an incidental finding on ultrasound or palpation. And what you do is you basically do a cesarean delivery prior to the onset of labour, because any pressure on those vessels during labour will, of course, potentially compromise the baby. Cord prolapse, okay, obvious definition, associated with malpresentation or a disengaged head. So if there's space, if the head's engaged well down towards the cervix, there's no space for the cord to prolapse. If it's a breach, or if it's a transverse lie, there's more space for that cord to sit and then to fall out. It reacts particularly to the cold and touch, so you can get a spasm of the cord and therefore asphyxia of the baby. Management of this, if it's noted, and is to call a code, replace the cord into the vagina and above the presenting part if possible, and whichever clinician does that or nurse does that then has to keep their hand in place until the baby's delivered by the cesarean. So they're trying to keep baby off the cord, so they're either pushing the presenting part back or keeping the cord in place, and they'll then be transferred down with the mother to theatre and will remove their hand only when the baby's been safely delivered. Shoulder dystocia, essentially the shoulders don't fit through the outlet, and so you get this turtlenecking, which is essentially where, as a contraction occurs, the baby's head appears, looks like it's proceeding normally, and then at the end of each contraction, it recedes again because the baby's shoulders can't fit past. That sort of forward and back motion is normal for 1 or 2 contractions, as the mother's just getting ready to push the shoulders out, but after that, the shoulders should then be delivered and the baby follows. Risk factors, of course, are maternal anatomy, and so previous occurrences of this, a larger baby, post-date pregnancies. Risks or complications is you can compress the cord, you can potentially damage the clavicle or the brachial plexus as well, and of course damage to the mother from having a larger baby. There's a useful sort of mnemonic to go through in terms of the management. So you call a code, you consider an episiotomy to make everything a bit easier. You do legs in a McRoberts position, which is essentially bringing the thighs up towards the abdomen. You put suprapubic pressure on only when the whoever's doing the accoucheur, so the person doing the delivery, tells you to try and push the baby's shoulders underneath that bony pelvis. You can the obstetrician can do some rotational maneuvers to try and rotate the shoulders round and to disimpact the shoulders off that bony pelvis. You can try and deliver the arm, so you try and sort of pull the arm across the chest and try and deliver that, and then squeeze the shoulders in by doing that. And then you do your last manoeuvre of last resort. So this is rolling the mother onto all fours. Potentially, the Zavanelli manoeuvre is trying to push the baby back up the birth canal. Has horrible consequences in most cases, but it's one of those things of life and death at that stage. There's not much you can do. Most of these, the shoulder dysocias, almost all of them will be solved by very simple measures such as suprapubic pressure, legs in the appropriate position, and some rotational manoeuvres. You, of course, need to debrief and document as well. Amniotic fluid embolism, the only reason I put this in there is for the buzzword fetal squams found in the maternal lungs. So a woman that's collapsed, who's pregnant, she had an acute maternal collapse. If the buzzword in the MCQ says fetal squams found in the maternal lungs, it's an amniotic fluid embolism. So these are the sort of the fetal cells from the amniotic fluid that are found in the maternal lungs, which of course were not where they're supposed to be. I don't know why Monash decides to focus on this. I would presume this condition is extremely rare, but it's one of those buzzwords. PPH is greater than 500 ml of blood loss. You prevent it by doing active management of the third stage, which of course is that oxytocin at the delivery, controlled cord traction, fundal pressure, etc., and results in annihilations basically from loss of blood. This goes across 3 slides, so I'm not gonna go into the depth because you need to just learn it yourself. But essentially, you take a quick history, you call for help, assess their conscious state and their hemodynamic state, and then take a quick history from the midwife, the nurse, whoever's present. Initiate resuscitation, so you're trying to get them their fluids stable. You then try and look at the cause. Uterine atony is the most common cause. So this is where the uterus doesn't contract as it should following the delivery. However, things like retained placenta or products, vaginal lacerations, hemostatic disorders can quickly rule out. So that's the type of thing you'd ask in a history. Is you'd say, okay, has the placenta been fully delivered? Is it complete? Can we look at it? Are there any tears that you've noticed? Does she have a history of hemostatic or coagulation problems? No. Okay, most common cause is uterine atony. And then you medically manage that by basically massaging the uterus, injecting a number and giving a number of medications, and then uterine packing. So you do you basically pack the uterus to try and prevent the bleeding. If that doesn't work, and in an OSCE they generally say the bleeding is still ongoing, what would you like to do next? You then do surgical management. You transfer them to theatre. You do a GA. You examine in theatre when you've got proper light and visibility. Prostaglandin F2 alpha is still in the Monash prompt guidelines. However, is no longer stocked at Monash, so it wouldn't be used. And then essentially you ligate stuff until you do a complete hysterectomy. That, of course, again, is very rare that you'd have to go all the way down that. Most of it's managed by giving it an extra dose of syntocinon at the start and doing a bit of fundal massage. However, you do need to know that entire step ladder for an OSCE. Uterine rupture is generally, as we've said about VBACs and about caesareans, they reduce the strength of the muscle, and you get this scar, tenderness, and vaginal bleeding. Contractions, of course, stop completely as the uterus ruptures, and decelerations are very quickly present on CTG. Essentially, immediate resuscitation, immediate laparotomy to deliver the baby, and then you do often a hysterectomy at that stage because uterus is just, often the tear is just too large to repair. Uterine inversion, exactly what it says. The uterus proceeds down through the uterine cavity into the vagina and potentially outside as well. Generally caused by traction on the umbilical cord before the placenta is adequately separated, and that's why you do controlled cord traction. Management is don't remove the placenta if it's still attached because it's actually helping to control the bleeding at that stage. You replace the uterus through manual compression. You can use warm saline as well. You actually give tocolysis there at that stage to try and relax the uterus to allow you to replace it, and then you'd give more syntocinon to try and then contract it again, and surgery as the last resort. Okay, so they're mostly emergencies. Preterm birth is essentially a delivery prior to 37 weeks of gestation. It's fairly common. Well, it's not rare, and most of the time it's caused spontaneously for no real cause. However, there are a number of causes that we have mentioned throughout the lecture. Most treatments aren't helpful. You can use cervical cerclage if you find the cervix is effacing and shortening. You can use progesterone, smoking cessation, bed rest, and antibiotics. But essentially, what you're trying to do is you're just trying to manage what it is. You will take a history and examination. It's got all the signs of normal labour, except that it's before 37 weeks. You can do this fetal fibronectin, which is this glycoprotein that can be found. Positive result doesn't really necessarily indicate the onset of labour. However, negative result gives you a very low chance of having a delivery. It just adds to your clinical diagnosis. And of course, you can do a vaginal examination as well. Management depends on at what stage the preterm is. So steroids under 34 weeks, as we said earlier. Tocolytics only if you're trying to transfer the baby to a suitable facility. So if they're in a tiny primary hospital out in the bush, you may want to transfer them if it's too premature. Antibiotics generally not recommended until you've got prolonged rupture of membranes, so long, like over 18 hours, or there's evidence infection. Magnesium sulfate for women under 30 weeks and transfer to a tertiary unit. So preterm, pre-labour rupture of membranes. The woman isn't in labour, but she's ruptured her membranes. Pretty obvious for most women, it's a gush of fluid. You're basically trying to avoid all chances of infection. So these women are admitted to hospital. They don't have VEs. They are given antibiotics. You monitor mum and her temperature and her vitals. You monitor the baby. And you try and keep her in that sort of state, despite the fact that sort of protective barriers of the baby has been removed. Try and keep it like that up until 37 weeks. Antibiotics, initially it's just erythromycin. If it's an earlier gestation, baby's more vulnerable, so you hit them with harder antibiotics. And of course, if there's any systemic infection, you go hard and hit them with fairly broad spectrum antibiotics as well. And again, sorry, you do need to know all of these. Mentioned the corticosteroids, we've mentioned the magnesium sulfate, and timing of birth, again, risk versus benefit, generally between 34 and 37 weeks for the preterm, pre-labour rupture of membranes. And we've mentioned the fact that you need to look at the temperature and pulse, the vaginal fluid discharge. If there's an infection, it will become foul-smelling. It'll look different, and you do your blood cultures. That's in comparison to a term pre-labour rupture of membranes. So a term, you're not so worried about having to try and prolong the pregnancy. You're just worried then about, okay, let's induce it. So for most of the time, about after 24 or 48 hours, you will induce it, no later than 96 hours. But most of the time then in that case, you're saying, okay, baby's ready to come out anyway. All we're doing is going to increase the risk of infection to both the mum and the baby, so we might as well get baby out of there. And so you do an induction of labour. Of course, if they're GBS positive or if they've had a membrane rupture for greater than 96 hours, you would also consider antibiotics. And if there are other signs of infection there as well. Induction labour, again, as I said, at term, you do it at the earliest opportunity. I've harped on about anti-D. Just remember the pathophysiology behind rhesus isoimmunisation. You've got a negative mum, you've got a positive dad. First pregnancy, nothing's going to happen because the mother only has the time to develop IgM if there is contamination. IgM doesn't cross the placenta, so that baby's safe. The problem is in subsequent pregnancies, if again, mother is negative, dad's positive and baby's positive, by that stage, mum's developed IgG, which can cross the placenta, and so the baby's potentially at risk. Once mother's been sensitised, you can't remove that, so we try and prevent the sensitisation actually occurring. And so anti-D, IgG basically mops it up before the immune response can actually occur. And I think I've said that. And yeah, basically it gets worse with successive pregnancies, and you may actually have to end up doing fetal blood transfusions for women. And the last slide is essentially after the pregnancy. So you need to talk to, and this is potentially also an OSCE station, a postnatal station. You need to talk to them about how the uterus involutes. So it goes from weighing about 1 kilogram at term back down to 100 grams. The cervix will close down again. That the lochia, so this is the discharge, the final discharge of the endometrium and stuff, will initially be red. It'll become sort of pale red, and then it should clear completely. How to manage any tears. The fact that bladder and bowel actions may be a little bit different for a while. Also, they'll be urinating more because of that hemodilution of pregnancy that occurs, so they'll lose all that fluid again. Consider the social emotional changes, consider partner support, home support, financial, those sort of things. Contraception, most women will be natural contraception for 4 weeks. If they're then breastfeeding afterwards, most of them will have contraception, sort of a lactational contraception. However, that isn't guaranteed, so talking to them about different contraceptive methods is a good idea at the same time. And talking then to them about their breasts and breastfeeding, and for anyone who's done a day with a lactational consultant, the first hour is really beneficial, and after that it just declines in its use. But consider the fact that women do have problems breastfeeding, and the problems that they may have with their breasts, and the fact that you need to warn them about them, and also say that it's completely normal and there is help available. Okay, so that's basically the end. So we've gone through all of the conditions on the left, and yeah, really well done for staying awake and for actually coming down on Friday. So thank you very much, guys.